Well, tell you what, why don't we get a head start, shall we? Should we give ourselves a kick start? Yeah, good. Good morning, colleagues, and warm welcome to this Public Board of Directors meeting. Public, a simple word. There's still a few things for me to say. First of all, we are being filmed. We've been filmed. Andy is filming us because for the first time we will be putting the Public Board onto YouTube. It's a pattern been using in another trust, which now receives regularly 500 views of the Public Board, and I kind of aspire for us to do a bit better than that and have made this even more public. We have some visitors here, and you're very welcome, and we have some others online observing as well, and you're equally welcome. So that's the first thing, we're being filmed. And the second thing is, I hope you noticed, those of you who are observant, is we have significantly shifted more business into the Public Board and out of the Private Board. So for many of us here at the table, we have two meetings today. We have the Public Board and then we have the Private Board. And the Private Board is pretty short now because we're consistently and carefully putting more and more of our material into the public domain, and indeed now items have to have a justification for why they're being held in private, and of course there are such reasons, and that's legitimate, but the great majority of business, I'm hoping, will always now be available in public. So thank you for your engagement in that process. Looking at this agenda, it's taken us through, we've got a 2-hour agenda that includes a 5-minute break, and we've got a lot of really chunky, decent material, very varied. It's going to be one of those quite fast-moving meetings, I think. I'm really looking forward to it. Let's just get the business started then. The agenda, I'm hoping it's okay. Can I check, are there going to be any matters of any other business that I need to be notified of and make time for? No, then we won't need to take any other business. Then let's go into the minutes of 28th of March. Kelly's normal exemplary content. I've got no amendments. Everybody happy? And are you happy that all the matters are picked up elsewhere? I certainly am. Then we're happy to approve those minutes. That's great. Then we're into my chair's report. To start with a couple of things. First of all, a warm thank you to you. Colleagues probably will know, everybody will know, last night I was confirmed as the shared chair across Newcastle, Northumbria and Gateshead. I've been really proud to be the interim chair here at Newcastle for the last 10 months, but I feel even more proud now to become the substantive chair, and here it makes me feel that much more part of the family. I have felt part of the family throughout, but slightly like the person that might be marrying into a family and might not. Well, I got married yesterday, and that's what it feels like to me. I'm really grateful. I'm grateful for the support you've given me throughout the process and the messages I've received, which have meant an awful lot to me. So thank you. The next...
sorry, just congratulations.
That's really sweet of you. Part of the process I went through was having to set out my vision for the Alliance, that some of you were in the stakeholder panel for, and Robert suggested that I share that at some point, what setting, I don't, but maybe talk to you about it, seize a 10-minute slot to talk about what my thoughts are, and then you can criticise and change and all that, but that's the game. And the next stage of, as it was stabilising us and knowing where we're going, the next stage is that the governors will be appointing a vice chair. We have an excellent vice chair who is also an interim like I have been, but we're moving into the establishing things, and over the course of the summer we hope to be able to appoint a more permanent vice chair. The governors will feel a sense of ownership and support of, and I think that's going to be very important for us. So apart from that, I've set out my chair's report, which I'm happy just to respond to any questions. Maybe the one extra bit to say. It's the nice messages we've been getting from Eddie Howe, who some of you may know is the manager of a local football club. But we also got some brilliant input from a number of Newcastle United team around the International Day of Midwives, because an awful lot of the children of the Newcastle team seem to have worked their way through our maternity services. Of course, other football teams may exist, but it's great that we're building that relationship with Eddie Howard and his team. Apart from that, my paper, I hope, sets out the range of activities. I'm really happy to take any questions or comments on that. You want to get into the real meat, don't you? So, Rob, what's happening?
Thank you very much, Chair. I think I was going to put my slides on the screen. So just a few things that I was going to cover today. We've got the normal dashboard that covers off our big signals. I've also done a structured page that just gives you a bit of a sense of the things we're currently focused on within that. But I think it would be remiss of me if I don't start with the financial context, and I know we'll cover some of that later on in our meeting as well under the integrated performance report. But at a kind of high level, really good outcome from last year. Lots of hard work to get us to a break-even position. The submission though then of the balance plan for this year was obviously the next objective, and I think Joe will take us through just a little bit more detail in terms of where we are in terms of the kind of detail of outturn plus the movement into month one. But a headline here of a really significant cost improvement programme that we need to deliver here in Newcastle of over £100 million. So a complete focus on reducing waste, improving that kind of approach to cost base, removing inefficiencies and increasing productivity with a number of things in place to do that. But I think it's fair to say that we are having to consider and go much further than that. And in the last month we've made the decision and put in place a corporate vacancy freeze as part of the plans to be able to make sure that we do deliver the financial plan that we need to. That's being overseen appropriately with the right input and impact assessments where necessary around any quality impact, but we're doing it in very targeted areas on the basis that we will be able to manage that really clearly. I think the other aspect of that is just as we move forward, really thinking about every service line, and Patrick and Jackie have started to have a think about how we do that. I don't know if Patrick can just maybe comment just briefly on the approach we might take there.
Yeah, I was going to mention it in the IPR, but happy to mention it now. So, given where we are in terms of our financial position, we need to. We always have planned to do a number of service reviews this year in terms of looking at potential vulnerable services, workforce point of view, etc. But we're shifting that slightly, so we're going to expedite a series of reviews where we know there's a significant income/stroke expenditure mismatch, so where we're not getting paid enough money to deliver services is currently configured, or where there's productivity challenges. So we're going to bring forward that series of service reviews, trying to get those done in the next 3 months, just because of the significant financial challenges that we have. So there's always part of our plan, but we're going to pivot slightly in terms of the focus of those reviews and bringing forward those reviews.
Very good.
So moving on then just to our kind of key big signals, and a couple of things I just wanted to pull out. So in particular, technology will play a big part in how we improve the way in which we deliver patient care, but also how efficient we can be. And colleagues in the last month across both our digital team, operational teams and clinical teams experienced in the first bank holiday in May the transfer of our electronic patient record to the cloud. Doesn't sound like much, but it was a huge undertaking from all colleagues concerned. Really fantastically overseen by Luthea in her role as accountable emergency officer, Dave Elliott and the team through digital, but also colleagues like Sue from an operational perspective, making sure that we remained very safe throughout that period of downtime where we were essentially back on paper and then moved across. That has now happened. We are now in a position where we can therefore get substantial upgrades to the system. The system stability should be much better, the speed of the system should be much better, so we're starting to see some early signs of that, but there's more for us to do, and I'll be pressing Cerner to make sure that they deliver everything that we would want from them as part of that change. Alongside that, we've also made a switch in our reporting systems for incidents and moved from Datex to Moonphase, and Rich and her team have already seen that. Really, really important shift. The additional capability of that system it is really important to us in improving our safety systems and our governance. But actually, the really important thing just on that transfer was making sure that we didn't see or have a significant dip in the reporting of incidents, because it's one of the things we've clearly focused on over the last 12 months is improving reporting systems. And I think it's fair to say, and already feedback actually from non-executive colleagues, that there is a real sense from staff that they haven't really noticed a massive difference. They know about it, but they're continuing to report and they know how to report, and therefore we're assured that that system switch hasn't created any challenges for staff, and therefore going forward we'll get all the benefits of the additional modules and system capability. And then finally on this section, just our approach to how we have reshaped our governance and the approach to our well-led element of the CQC inspection. We're now preparing for the external well-led review. This was commissioned by the Trust. We're currently in the process of commencing procurement for that with a plan to do that now within the next 8 weeks, so that we will go through that external well-led process, and that will enable us then to provide additional assurance to our regulators of the improvements we've been seeking to make over the 12 months.
And we'll discuss more of the details of that and try the board later on today. Yeah.
And then I've just included patient experience key messages. Obviously, as we roll out further into more of our wards with 20 deadline in June, we'll see more of this data enabling us to pick up those themes. There's a couple of additional new themes there that we're picking up from inpatient areas and maternity. All of this is fed back to those areas and enables them to then develop their plans accordingly to support improvement there. I thought it was important just to cover the capital programme. I know that through Finance and Performance Committee we've seen this and we've approved this in private law last month, but from a public perspective, for everyone to be able to see that we have a really oversubscribed capital programme. We have a limited resource for the size of our organisation. Paul has done a fantastic job working with our clinical leadership team to really align the programme to meet the clinical priorities, but also to deal with those infrastructure requirements that we have as we've got huge buildings which are very, very complicated. And therefore that balance of making sure that those infrastructure elements are safe, while still progressing improvements in the environment for our different clinical areas, is really, really important. And then finally, I just wanted to touch on the work we're doing in the Newcastle system, the Newcastle Place. We had a first workshop a couple of weeks ago now to start to develop our thoughts around the integrated neighbourhood teams and the approach to how we will deliver that. We've got further timing in June before we then start to engage much wider in that development, which will be really, really important for what we've been focused on in reshaping our own community services to be part of an integrated model with colleagues in social care, primary care, voluntary sector. And it's great to see our new Director of Community Services joins us from the beginning of June. And we've also got Dr. Sarah Ray, who is a local GP, who has come on board as our Clinical Director for Community Services as well. So we're starting to form a new leadership team with colleagues in those different sectors to start to develop that approach. And I'll conclude there and happy to take questions, Chair.
Thank you. I think that last item on integrated neighbourhood health teams, we're going to be talking more and more about that over the next few years. I suspect in 5 years' time, when we've stabilised our finances and everything's going wonderfully, it'll be the head item in the report.
Yeah, so I've got a couple of points. One's on finance, but I'll probably leave it till then, but just to give the headlines so that you can think about it, is there's obviously been a lot of noise around the impact of having static elective funding, and what does that mean for us as a trust to reduce our waiting lists, but also from an income point of view. And then the second one relates to state support. There's lots of stuff that we are going to be doing, but what I would like to understand are if there's some projects that staff are expecting to be delivered, and there's one that I'm thinking about, which is the ambulatory care unit at NCCC, which was supposed to be going downstairs. Has that been mothballed? And if it has, have the staff been made aware of that and the reasons why?
Let's just look for a response on both of those. First of all, on the elected,
If I give a headline and then maybe colleagues come in, what we're doing is seeking to take a targeted approach to make sure we balance what we require from a performance perspective. That the activity plan that we have to agree with commissioners it isn't open-ended, and that's not that unusual in terms of your past history. That you have to agree an activity plan. What we've sought to do is to try and make sure that we maximise the opportunity within that activity plan, but we've also taken some risk in that we're planning slightly more than what's in there, and we'll work through the implications of that throughout the year, just to make sure we remain ambitious on reducing our longest waiting times.
Anything to add on that? That cover it?
The only thing I was going to say, Chair, is we'll need to monitor activity really carefully throughout the year, because there may be a conversation with commissioners later in the year about whether we have to slow the pace of delivery, and we'll have to work through at that point what that means from a performance delivery point of view as well. So that's going to be really important as well.
And I suppose it's about the messaging of that to staff and
Absolutely.
our public really moving forward.
And also we're obviously monitoring that very closely from an income perspective. From the month one report, we're trying to focus on those risks and that forecast going forward.
Sue, anything to add?
I think just to give assurance that we are absolutely focused on reaching our activity plan and about clearing our backlogs. We've set an ambitious target to get down to 52 weeks by the end of the year. So we need to put activity through to achieve that. So I think whilst the contracting conversations are part of the wider discussions, the teams are really clear that clearing the backlogs and getting patients through in a timely way is their key priority, and that's what we'll focus on.
Okay, we're pushing on, pedal to the metal. If we're forced to slow down, then let's handle that when we get there and look at the comms from it. Estates.
So I'm happy to have a chat after the meeting, because I've got nothing that says we're more forward than anything in terms of ambulatory care for the cancer setting. So I'm interested where that's come from, and I'm happy to have a chat with whoever it has come from. We agreed private capital programme with the 2 lots of testing with trust management group on priorities, and we've shared the programme inside the organisation. What we're coming back with, and we'll head toward eventually on, is an outlined 4-year programme, so we can show you what's happening, but more importantly, for our teams, as an exec, we want to show everybody that's the plan. We want people to understand we're on a list. We want to make sure that the theatre refurb and water refurb programme is understood within the organisation. And Sue and I spent some time this week making sure we get all the directors of operations and deputy director of operations thinking about what that means and understanding what is and what isn't happening. So happy to come back on that.
So I think we've got assurances in mothballing, but we'll have a separate conversation outside to handle it. Bill.
Yeah, there was just a general question, Rob, because obviously we saw yesterday announcements about proposed pay increases for various grades of staff. There's a range of officers, and that's going to play out on a national basis, and hopefully we won't see industrial action, but there must be some risk of that. So I just want to what we're doing locally to try to make sure we're as well engaged with local staff groups as possible, so we can manage any local impact of those negotiations.
Yeah, and Michael might want to comment, because we had the NEC yesterday, which is our meeting with the VMA colleagues and the local medical leadership. But on a broader level, clearly we now have that information. We have really good plans that we have used in the past to manage any industrial action. We will continue to engage locally, and we've always taken the stance that the local engagement is separated from any national dispute. So we have to maintain, and it's really important that we maintain really positive local relationships. I don't know if Michael wants to.
Yeah, I echo that completely, and clearly we hope that we will not end up in a situation of industrial action by any staff. But if that situation arises, then as Rob says, we have good plans in place for how we manage that and keep the hospital safe. And that is always our prime priority. As Rob suggested, in terms of senior medical and dental staff and the resident medical staff, there is a risk that we will see industrial action at some stage in the future by both of those groups. It's under consideration by both groups. We had a meeting with our local negotiating committee yesterday, and we'll continue to engage with them as this progresses.
Okay, so it's clear risk, but we're started on it and working on it. Good. Any more questions, comments, challenges to Rob? Thanks, Rob. That's really good. Let's move into the strategic items, and we've got patient and staff stories. I forgot to take apologies incidentally right at the beginning. I'm sorry. And Annie Lemonsy, who was normally presenting, is doing that. Who's presenting on this one? Leanne's coming. Okay. Scary story about the Royal Navy Lieutenant Commander. Quite a striking person. So, Leanne, warm welcome. Good to see you here. The patient story, you've brought us the Lieutenant Commander and his renal failure.
Yes.
Scary kind of bloke, I think. Do you want to just pick out any highlights from this, and then from that lovely story about Alison?
Yeah, so just basically a lot of the work that went around this when he was actually diagnosed with renal failure, it came out of the blue for him, and he had no prior symptoms previous to that. And what now has happened is he's now on the transplant list, so he'll be able to get a new kidney as soon as that's available, whenever that is. But what that does highlight is the work that the team has done in Newcastle is they've worked with a lot of the pharmaceutical companies that were involved in all of the processes around providing drug, so that when people are given their transplant, drug is available immediately. So that wasn't the case beforehand, and so if they do get the transplant, if they don't have the drug at the same time the transplant, the same thing may happen with their kidney again, whereas now they've got the reassurance because the team have worked and kind of negotiated with the pharmaceutical companies that drug is available, and if that drug expires, they will replace it free of charge. So it's of no cost to the establishments, so that when he needs that drug, it's there and available, and it won't affect the new kidney that he's had. So that has provided a lot of reassurance for him.
Very good. Any questions? We'll come back to Alison afterwards, but questions or comments on that? It's a real teamwork, not just within the trust, is it? It's a wider than that, Ian.
That was exactly my reflection, Chair, just reading through that story is we often forget to see the impact some of our teams have nationally, the influence of some of our teams in terms of being able to provide high quality care in their local place, actually across the whole of the UK. That service particularly absolutely demonstrates that impact. It made me reflect on how we make sure we capture individual patient experience where they may be in different parts of the country, but absolutely there was some learning for us organisation, and I guess that story really started to highlight that today, so thank you for sharing.
Thank you. Then what about Alison? What a nice story about Alison there.
Yes.
It's so easy to overlook, but certainly my own experience when visiting wards is I tend to hone in on the housekeeper at the back, the heart of the place often. Yeah.
So she particularly had a lot of when the patient facilitators went to get feedback from the patients, she was the one person that they all talked about. Just that when they were feeling down, she kind of uplifted them and made them feel really good. Just her smile in itself when she came to see them made them feel a lot happier. And that was across the board with all the patients that they spoke to. And when you hear that feedback, it's fantastic. But when the facilitators went onto the ward and actually watched her interact with the patients, they said that was even more powerful to them because they saw a lot of that genuine compassion and kindness that she displayed.
Good. It's just hard to do other than applaud, and maybe to remind those of us that are doing broad visibility tours, which is everybody, I think, to not forget them. That's great. Thank you very much indeed. These have been two really positive reports, and we kind of try to aim to alternate a little bit. I mean, not so crudely to say here's bad news and here's good news, but let's make sure we keep that in our mind as reports come through. Bad news is our friend, criticism is a gift to help us improve, so let's make sure that we keep on bringing them in to the board as well.
Thank you.
Thank you very much indeed.
No problem at all.
Right. And on a very similar theme really, those are a great opportunity just to kind of look through a window at what's happening in different parts of the trust. another party to the visibility programme. I've lost you, Rachel. Rachel, yes. You're presenting the report.
Yeah, thank you, Chair. That was a nice segue to discuss our board visibility programme. So for those who aren't familiar with this, so this is our formal set of reviews that get done, visits to wards and departments. There are obviously many other informal visits that also go on alongside this that absolutely help us inform any areas that are particularly doing well or any areas equally for concern and that we need to react to. So it's led between Kelly's team and my team because it has two streams to it. So we have the leadership walkabout programme and then we have the non-exec informal visits. So the leadership programme is some senior leaders, select senior leaders from across the trust, accompanied by a senior member of my team, and then the non-execs do their own visits. And one of the probably the updates from last time is that Kelly and Gavin Snelson from my team have worked together to try and improve the process. So on the back of some feedback from some of the wards and departments who felt maybe that they weren't getting any visits, or others equally who were seeing lots of people all within a very short period of time, which they weren't opposed to, but it does get quite busy on the wards and departments, and they felt like they were reiterating the same things. So what we've done, or what Kelly and Gavin have done certainly, is created quite a simple SharePoint document where we can keep track of who's been on the visits, and more importantly probably is we can record the outcome of those visits much more easily. Previously it was always done in a manual way on paper and then we collate that. So it makes it much easier to create reports like this, but also to give that feedback and share it more widely, and it can help inform things like our quality and safety peer reviews, etc. The full breakdown of feedback is in the reading room, but just some highlights really. So we collect the good and bad, like Paul said, you know, we need to hear the good and the bad, and it's great that the staff feel comfortable to raise their concerns with all groups of staff who are visiting them. Overall positive culture was reviewed and staff feel very supported. There is still some element of they feel comfortable to raise concerns, but sometimes they don't always know whether they'll be listened to and reacted to. So I think there's something about actually if we do something, we need to make sure that we're communicating that back. And if we're not able to react to that, equally we report that back. Lots of extremely positive feedback about the Accrediting Excellence Programme, which is being received by staff just overwhelmingly as a positive experience. Some concerns around some of the nursing night shift staffing resource, and all of these things that are for immediate attention get fed back to the relevant person. I know Ian, you collate some of that information and react to that immediately. Interestingly, there was also a lack of awareness at this point, because this was March and April, around our in-phase system. We've heard more recently that that has absolutely changed, and Rob highlighted that, and we are absolutely connecting that as a patient safety team. The feedback is very positive. So I won't dwell on anything other than that. I'm going to take the paper as read, and I would encourage you to read the full summary in the reading room, because it does give you a lot of information.
Thank you. Yes, it's a good read. Who wants to raise any comments? David first, and then Ellen.
Just very briefly to say that from the NED perspective, the walk-arounds are incredibly informative, very encouraging, but I think particular plaudits go to the executive team that respond to what you say, because we do get rapid response, and I think it really helps reinforce the fact that the staff are comfortable talking to people that they don't know particularly well. They're very open, but part of that is because they can actually see the response and action that we get from people like Ian. It never ceases to amaze me how quick Ian gets onto these things and the substantive knowledge that he has on all of these things. But that also gets fed back through the way in which we're aligned to the wards and teams. So the stream 2, which is set out here, Rachel, I think works very, very well. I suspect Anna has a similar view.
So I was just going to say exactly what you've said, so I'll just not say.
That's good.
Yeah.
So I would echo all of that, and I think that getting that rapid live feedback is really helpful, particularly in areas where we've got services with oversight groups or under action plans. Being able to just close that loop on some of those and test some of the actions and whether they're embedded through that process has been really helpful.
Good, good. But then,
Yeah, thank you, Chair. It's a super process, and well done, Rachel. Just from a non-executive perspective, I just kind of occasionally seeking assurance that issues that get raised get done. Often we get quite a quick feedback. It's been escalated, it's been sorted, that's fine. I have done some walkabouts where I went back to the same area. I can think of a case in Portland the last 12 months. They went back and the issue hadn't been resolved.
it's all hands on the stone on that.
No, to be fair, it's before the board's time, absolutely. So it's just a check and balance occasionally that some of the stuff that will take a bit longer, is a little bit trickier, doesn't fall between the gaps, because I think there's a high expectation if someone's raised it to an executive leader or a non-executive, and we commit to escalate through a report that there should be some action. I think in the vast majority of cases we see that action, but I think there's always a potential risk things fall between the cracks. I don't know, I'm not suggesting there's any need for some over bureaucracy to track these things, but I think it's just a reality that we just need to remind ourselves some things need to be followed up 2 or 3 times to give that assurance.
That's good. I'm sure that's fine. Yeah.
Actually, one of my reflections was exactly what Bernie's point. So 2 quick brief points to make. What I think has been helpful to see, and I really value particularly the non-exec director walk-arounds, it's been able to see the themes coming through that, also matching what's coming through the governance routes more formally, and triangulating those and starting to see them being much more cohesive is really quite encouraging. Absolutely pick up on your point, Bernie, is one, and that Aaron and I have both worked on when it was an immediate result and a positive feedback, I think. We've done some testing on that a little bit further down the line, and it's not quite as well as we hoped it would be, so we've gone through that route again. I think the point's really well made and important, particularly when we're talking around things related to culture rather than any of the transactional elements of the department. So we are testing that with the most recent example, but I think it's something we need to be cautious of.
Very good. Rob, and then
Yes, I think it's a really good point. I think we need to think though as executives also about how we do that and not automatically seeking to directly fix, but actually work with local line management to make sure that it's a really sustainable solution, because there's always that issue that we could go in and solve one particular problem, but actually we may not have taken into account everything else that's going on and understanding that full context. So working with local line management to coach, support and make sure that that then becomes a new way of doing things in a sustainable way that understands the whole picture is quite important. That probably takes a little bit longer sometimes, but actually as long as we're communicating well and we keep people engaged, that's probably a better way in the long term of getting where we need to.
Nini.
Yeah, I was just going to say that during the NED walkabouts, I've really enjoyed doing them at night, during the day, so you can see the difference. And I noticed in the report you said that some wards felt they were visited more than other wards, perhaps. And I just wonder, so I think it's good the kind of coordination you're doing with the SharePoint and the database. I just wondered about those non-clinical environments. Do they feel they're getting enough observational walkabouts? What's your perspective?
So I think that's part of the reason why we wanted to create a better system and a better process, because we potentially may have been biased towards some areas more than others. Now we can see that absolutely they are getting a balanced number of visits from both leadership and NED walkabouts, whereas previously we couldn't do that easily. So I think we haven't tested that, but that might be something that we can do at a later stage to make sure that everybody does feel like they've had enough attention from that process. But I think as well, to come back on the other point about the actual outcome of some reviews that potentially aren't as good and checking up on that, the new process will allow us to be able to coordinate those visits, and we will have those who are have access to the SharePoint can look at what the previous problems might have been on that unit, and therefore can do that check and challenge when they go back to revisit. So I'll take that point on board, maybe, and we can maybe look at bringing that back in the next report in terms of where's had visits.
Very good. And there's a balance between, centrally making sure that everything's covered and also allowing that spontaneity. I know from my point of view, if I hear an issue raised with governance, then I will tend to try and do an impromptu visit the following week when it's appropriate, whether it's in the schedule, whether there's been a visit 2 months ago or not, and we need to have that flex still. David, you see.
A very short point, and I think the point of assurance and indeed reassurance is that the staff are, or at least I found in my conversations, are actually very understanding of the environment in which the trust is operating in terms of speed of response. They know everything can't be done immediately. There's an understanding, and indeed, I would just they're imbued with patience. As long as they actually know where they are, they're happy to deliver the comments.
Good. Okay, so first of all, thank you for all the teams that have been doing the visits. We've seen a significant uplift in the number, and I believe in the quality of the reports coming through and the visits. Thank you, Rachel, for the coordination role. We're hearing that there is, on balance, overall good responsiveness. There's more to be done to check because there will be some occasions when not. So a little bit of kind of double checking and assurance will come in handy. I think we probably need a little bit more communication around some of the times when this works. In other words, I can think that just from here of several examples of where, as a consequence of the visit, a point has been raised and something's happened which has produced better outcomes for patients or for staff. And let's just keep a little bit of a record. I don't mean too formalistic. Let's make sure that we can communicate that. It's a little bit along the lines of you said we did, but just to demonstrate that this is not just icing on the cake. This is a crucial part of the quality assurance process for our trust. Yeah, that's great. Thank you very much indeed. That was a great report. And let's go on then to CQC update. There's a bit to do here. Ian, you're taking us through. You're leading on this strand of the work for us.
Thank you, Chair. Yeah, so there was a cover sheet and a number of slides in the package. I won't go through in detail. The student colleagues have read through that. Just a few bits I want to draw to attention. So I have noted within the slide that the Phase 2 action plan, which relates to effective governance and well-led, continues in place. There are 49 actions in total, of which a number are complete. There are 5 to note, which are behind plan and outline those within the report. We are aiming to have those resolved in June and I'll provide an update to the Quality Committee in the middle of June in terms of progress on those 5. I do want to note 3 of those relate to where the action has been completed, but it just hasn't yet gone through our governance process for appropriate check and documentation. So we will be continuing to track those over this month. The action plans, which very much relate to some of those subspeciality services where we know we've got additional oversight or improvement groups in place, they've all just been refreshed or in the process of finalising being refreshed, again to make sure we're testing evidence in practice, and again the Quality Committee are providing oversight of those action plans on a monthly basis. Colleagues will know that one area we wanted to focus on is using the value circle to help us check and challenge some of the embeddedness of the actions that have been put into place, and we commissioned a review of our cardiothoracic services, which took place in March and received the report in May. Encouraging to note some areas of improvement and some areas for further work. And the cardiac oversight group remains in place and they will provide scrutiny and oversight and will have a revised action plan in relation to those findings and feedback. And the report is in the process of being shared with local colleagues now that has been finalised, and will provide an additional improvement plan through the Quality Committee and which we hope to have completed in June. Our oversight remains in place with NHS England and the CQC and the ICB through our Integrated Quality Improvement Group. There was a deep dive bit of work I undertook with colleagues back in March, which led to a revised approach to our meetings in April. I think I mentioned to the board previously that we were using the process to ask for specific de-escalation of some services through the Quality Improvement Group oversight. And with that revised approach, we had confirmation that the medicines management oversight and maternity oversight didn't need to now go to IQWiC except by exception. That's not because we think everything is fixed, that's because we're assured around the governance processes and the actions that are in place, and we've got evidence of improvement across a number of domains. And we will be taking additional service again to the next meeting in June and to take a similar approach. I'll be working with colleagues week after next to, on the back of that, re-explore what our exit criteria looks like from that oversight group, or what de-escalation criteria looks like. And I would hope to have a discussion and confirmation of that at our next meeting, which is happening in June. And I think just to note, what Rob mentioned earlier, and what they're doing to develop a sort of external led review, and that process has commenced. In the meantime, Ellen Armstead has been supporting our local clinical leaders for the well-led development and feeding back to them any areas of good practice or improvement, and we'll continue to do that with the board as well. So they're probably the key points I want to draw to attention today.
Ian, thank you. Before I open it up to questions, let's just remind ourselves of the big picture, because in previous board meetings we have been assuming that CQC would have revisited by now. I remember us saying that we were expecting them before Christmas, and I remember saying we were expecting them early in the new year, and then we were hoping for them by Easter. We're now looking at next year, aren't we? But that's a good news story. Well, it's a mixture. It's a bad news story for CQC, who are still trying to make sure that they can tie their shoelaces before they go out the front door. But it's also because they don't think we're a risk anymore. All the evidence coming from all sources means that we're not flashing red flags. And that's a right bind, because it means that we don't have the opportunity to prove to CQC that our rating properly should be fundamentally different from what it was when they last came. At the same time, we should feel a sense of pride. Rob, have I characterised that? You've been having the conversation.
Yeah, yes, probably. The only thing I would say is probably not that they don't see us as a risk, that we're lower risk.
Yeah, okay, so that's
what I would say.
Yeah.
And so therefore they would prioritise other places over us at this stage. So, but yeah, it's a positive, but obviously it does mean that in terms of the criteria to de-escalate from the integrated quality improvement group approach, there was an expectation that we would be visited and that we would have a new well-led. That's the purpose of therefore doing an external well-led, and we've agreed with the ICB and NHS England they will use that as a proxy for the outcome against our de-escalation. So that's why our work will be really important.
So meanwhile, we still have a CQC action plan, and we've just received it. And are we content with the assurance it's giving us that we're on top of the processes? Anybody want to raise any comments or questions or challenge it?
It was just a comment, maybe. Obviously, we've been doing a lot of the heavy work through the quality committee, and we have actually been able to de-escalate some of the services of the CQC action log, because we've now got tier 2 committees in place who will be feeding the management reports in. So it's starting to become a bit more business like usual.
Very good, very good. Any more for any more?
Yeah, Chair, just again an observation. I mean, superb work, it's comprehensive and well tracked and challenged through the various board committees. So I think we're all pretty well sighted on the direction travelling and take assurance from all the great work that's happening. But I think it's just, I'm just conscious from the people perspective, particularly some of the well-led angle. These are kind of quite long, medium or longer term challenges. And whilst we're making some really good headway now, we can never take on all that. The embedded and shift on that culture will be a challenge way beyond just any forthcoming well-led inspection or CQC's inspections. That's a long-term game plan that we've got to keep. I mean, I'm pretty sure from my people committee, but I don't want to just comment.
I think to read the point, and it actually comes back to the point Jane made around that ability to be able to demonstrate progress, but absolutely acknowledge we've still got a long way to go. I think for me, having that CQC action plan, there's something around how we transition to our wider long-term development and improvement plan. And I've had a lot of conversations with staff in the water departments who said, we've seen the improvement, we know you said there's still some way to go, but have very much tied that in their minds to CQC rather than this is because what's important to us, because it's important to our people, it's important to our patients, and it's our direction of travel. And I think the more we can focus on that, both through the mechanics of it by putting it into existing governance processes, but changing it to this is just what it is around here, the things we want to focus on, the CQC will answer itself at the right point. And I think actually the delay of that just gives us some time through the section of well-led for that next period of time to try and take that mindset, because we know that work will take some time to embed to reach on those people in culture and function.
Okay. So we'll carry on receiving a CQC update, although I hope that we would be able to just knock it down into business as usual by now. But I guess until they come, we'll keep on receiving it. But it's focusing all the more on the assurance that the changes we've brought about are having a long-term impact and not just short-term. So thank you for that. I think we have received assurance about the progress against the Phase 2 improvement plan. We've got a sense of where we're going with additional oversight, and we're going in the right direction. And that's positive, and the sooner we can be fully de-escalated, the happier many of us will be. But great piece of work you're driving in, and thanks to all colleagues who I know are involved in it. If we go straight on, winter plan. As soon as one winter's over, the next one's coming, isn't it? So we're looking at what the learning is from last year, and in June we'll be looking at the winter plan for the winter coming. So Sue, you've been putting together some of the work on the learning.
Yeah, thanks, Chair. And Nicola's going to take over from me because obviously I wasn't here last winter. So in terms of the team's understanding of what's gone well and what hasn't gone well, it just seems slightly strange when the sun's streaming through the window that we're starting to think about winter. But we're in that planning phase already. I think in terms of looking forward to winter coming, I think we've embedded a number of things that worked really well last year and they're now becoming part of business as usual. We're working with the system partners to understand what their plans are as well, because we know if we don't tie that together, there may be some unforeseen consequences of people taking actions elsewhere in the system that then may impact on us. And I think we've got a bit of a delicate balance of driving elective activity and elective recovery through, obviously against the money position, but also around managing flow. So our plan this coming year is to take all of those things into account, plus our refurbishment programme. So all of those factors, it's a bit like a water table, it's a bit of a delicate balance. But Nicola's going to join in and take us through what went well and then what we're looking forward to.
Nicola, welcome. And you can assume we've studied and read the slides, so just pick out the highlights from them.
Do you want to say? Is that okay?
Okay. But assume that we've read them, Nicola.
Yeah, that's absolutely fine. So I think Sue's covered a couple of the points that I want to draw out. So things that went well is that we always kind of build in additional capacity. So the pressure is on our beds during winter pressures. So that tends to work well. We create that capacity going into that Christmas holiday period. So actually when we start to get busy, post-Boxing Day, we've actually got patients and we've got good flow through the hospital. The things that Sue talked about, what we're starting to embed is things like the frailty at the front door. So we established a new model this winter on the back of some BCF funding, some slippage, and we're continuing with that model and it's having some real success. Just converted that this week to a frailty SDEC, and actually we absolutely are turning patients out the front door, same day emergency care. And the integrated discharge teams, they've been working all year in terms of that build-up to winter to change their discharge model, and they're having a real impact in reducing length of stay for patients and actually moving them on and transferring to their next phase of care or getting them home. But actually we're shaving days off, 3-4 days off length of stay, which is great. So that's again had a really positive impact. Some of the things that again we talk about the discharge lounge at RVI. We put a discharge lounge in the Freeman last year, again as another exit strategy to move patients on to the next destination waiting for the discharge, freeing up beds much sooner. Ideally we'd want to discharge them from the wards, but discharge down that just give us that outlet. And additional transport, so when we open our additional bed capacity, it tends to be over the Freeman where we've got some space. We've got a decant ward there, Ward 12, and we need that transport to make sure we've got that timely transport of patients between sites. We have historically sent patients quite late at night. Having that additional transport during the day means we can keep that flow going during the day. All of this is kind of telling in the performance. There's a slide on the performance. We did get better performance this year. Still not where we need to be, but in terms of our A&E performance, our ambulance handovers, some delays over 60, but more were completed within 30-minute handover. So some really good signs of a really planned winter plan, executed, and we saw the benefits in terms of flow. We did support the system. I have that on the other slides, it did go well, but actually the teams really feel that pressure when we're taking diverts from other hospitals, when, quite rightly so, we need to know what they're planning. So we did support the system quite early on, from about November, December onwards. Our elective programme, we were able to keep the elective programme, but we had challenges within ITU, and a lot of that was due to staff sickness, but also our paediatric intensive care units were really stretched as well. We did a lot of support between the both sites, between the Freeman and the RVI. We had some national patients who were due to come in, who had to delay on the back of that. And that was all around national pressures around RSV and some really poorly children. So that's definitely a lesson learned, because we were still trying to keep going with some quite challenging elective cases during that time. And that's on our lessons learned in terms of what we're doing for this winter, in terms of better elective planning for those complex cases at that time. So lots of learning that will pull through into this year's plan. We had a meeting yesterday, we've got another meeting next month with a view to bringing a plan back to the board next month. I'll pause there, happy to take any questions.
That's really great. Liz.
Yeah, I'm just interested in the impact of staff sickness. You know, all this planning and all the capacity. If staff aren't available, it's such a problem. So what additional planning are you putting into place to cover off staff sickness? And I have particular interest because of the PICU, the maternity services. I also am aware that there's a fairly high number of midwives who are expecting babies of their own. So that's another consequence, because that will hit in this time period.
So we did touch on that yesterday in terms of the planning around that. There was always a challenge, because we pull on some services as well to support in the winter ward. So that's something that we agreed to look at for those areas in terms of when they would need to be released, or actually how many would need to be released when actually their staffings are much more challenged. In terms of the critical care, so we like it's again encouraging vaccination, cover, and it worked really well between the two sites last time. We did bring the teams together, and we just want to embed that practice so that they're routinely doing that rather than kind of it escalating and we're having to get the teams together fairly late on. We want them to be doing that plan, that joint planning together. So we've asked them to come up with that plan yesterday.
Great, thank
and
you.
I think in terms of the staff sickness piece, you probably want to come in here, but as part of our overall planning, that's an area from a productivity perspective that we need to really focus on. So I think we're starting to talk about targeted interventions to try and manage staff sickness more effectively, make sure that flu and the vaccination programmes are, you know, delivering what they need to do to try and prevent those numbers.
Hassan.
Thank you.
Thank you. Hassan.
Thanks, Chair. I think this is really good and it's really clear in terms of what we're planning to do. But with a plan and then the execution of a plan, my assumption is there's some governance and then there's a team. Could you just talk us through how we are governing the kind of robustness of the plan and then the execution to make sure that it is successful?
So we've got a planning team, and that's made up of representation from the departments and a representation from each of the clinical boards. We've got an emergency care group where we've been routing some of that planning discussion through there, which is one of our improvement groups, and it's very much around that management through the front door, things like that. Our auto escalation is going through that group in terms of making sure everybody's got their action cards up to date when we're in that surge position. Then absolutely people have got refreshed clarity around the actions, what they're expected to do when we're in some local status. In terms of the governance, in terms of the plan sign-off, that will be routed through to board.
Good, okay. Via Quality Committee or Performance Committee? There's usually not in performance, so you need to do performance. I've got Bill, and then I've got Wendy and Anne.
I think you've actually touched on what I was going to say, because I remember when we were in midst of winter last year, we were going walkabouts. Flu was having a real big impact on bed availability and respiratory conditions, so I don't know what we could, yeah, we've seen a drop-off in staff vaccinations, what can we do to try to address that? And I suppose community vaccination must have a big impact on that as well, so I'm sure you'll pick that up as part of your planning for...
I know the people in the committee are looking properly at that, aren't they? Yeah. And you want to just respond to that point?
Just from a vaccination perspective, we've already kicked off this year's vaccination steering group, just to be able to link in with the national team to do some key learning from last year in terms of how we might optimise vaccination this year. And those plans have already started to try and see if we can increase the from the previous year's learning from last year. And so that plan is already in place, and again, I'll provide an update to the board on due course as that progresses.
Excellent. Wendy.
Really interesting to see this, thank you, and I think it's great that you've done that piece of work around evaluating what the learning is. I noticed that there've been really positive about the frailty work and also about the additional discharge lounge. You did mention, you talked about ideally you would like to shift to why can't we discharge more people directly from the wards, and I just wonder if that's what your thinking is around that, what would help that, or if that is that going to be part of the plan for the coming year?
I don't think it'll be part of the plan for the coming year. There's quite a lot of work to do around that. Some of it's that working with our PTS colleagues. So we do have a lot of reported journeys, so patients won't be ready when PTS turn up. So we're working with NIAS on getting some really good data that we can then tackle that with the wards. Medicines management is a huge piece of work that Julie is leading on. That will help with the timely getting the patients their medicine as well. So sometimes the patient just goes to discharge time because they're waiting for the medication, as well as that transport pickup. So the more that we can put up front and do that discharge planning, the more opportunities there is to discharge from the board.
I've got Anna then Phil.
Yeah, so just a really great slide deck. My question is, how are we sharing it with our people on the ground and sharing the learning from last year and the plans moving forward?
So we've done a few sessions. We have a number of office meetings throughout the course of the week. So some of the learning's gone through there, and that debriefing, people have had an opportunity to comment what worked well for them. We picked some of that up in the...
I'm talking about the nurses on the ward that can't get off the ward to get to a meeting, because they're the ones that are going to be key to delivery of whatever you're implementing, and they can't come to ops meetings because they're caring.
Yeah, so we have asked the representation from each of the clinical boards to be representing their board. But we probably need to be more explicit around that. They need to garner some of the views from their frontline staff. But a lot of that comes through some of the nursing routes, so we'll get input from Lisa, for example, who attends the meeting. So it does filter up, but I don't think we've done anything trust-wise in terms of a
I think we're in the early
workshop.
stages of this.
Yeah.
I think it's part of it is about the evaluation of what worked well and about the things that we need to embed now. I think as part of the planning process and what we agree is the plan for next year, that engagement and the comms piece is critical to making this work. So that'll be a work stream as part of the wider plan.
Good, Phil.
Two questions. One, first one is, you mentioned that you've taken 3 days off the average length of stay. Have we had any concern raised by relatives that their patients have been discharged too early? And have we noticed anything in terms of readmission rates related to that? And the second question is a bigger one, which was at medical director Ian. A lot of the short-term illness during the winter, which Liz alluded to in terms of staff shortages, is adult RSV. Is there going to be any scope to offer RSV vaccination to our staff population?
Okay, first of all, patient feedback and readmission rates.
So a lot of the delays are very much social. So from a medical perspective, I'm not seeing any triggers around some of the readmission rates. But we have got patient feedback as part of that work, and happy to bring that.
Can we just drill down and check and get check on that? Good. RSV for staff. RSV, Jack.
I actually don't know the answer to that from the update from the vaccination group, but I'll happy to...
Let's find out together. Nini, you know the...
I'm staying on to ask questions.
Yeah, okay. Julie, you might. Of course, yes, you're there, you can answer that question.
Yes, just for the staff vaccination, because the criteria is very tight for RSV, it will have to be an immunocompromised cohort of staff, which is what we do for patients as well. So it's very restricted vaccination.
Okay, so that may be a non-runner. Yeah.
It is being rolled out to maternity paid pregnant ladies, so we'll that will help us with it.
So there's a selection criteria.
Okay. Nini, that might be it for this one. Let's just see.
Yeah, it was just building on Phil's point a little bit, which was that in the evaluation of the winter plans and how it went last year, has there been anything to look at kind of patient experience and what that was like, and do we therefore have any targets around what we're trying to do around patient experience for this winter?
So we've got all the real-time information, so we do get that patient experience, but haven't pulled it into this piece of work. So it's something that I'll pick up with Annie obviously going forward. So we have made a lot of changes, we'll be making more front changes at the front door for this winter with the UTC. So we'll build that into the plan as well.
Okay. Yeah.
Can I just make a couple of points to it? So I think it's really good, actually, it's really good to see the full evaluation of all the work. There's clearly a number of areas where we've improved but want to go further, and you've mentioned some of them around ambulance handovers. Patients in ED over 12 hours, the numbers came down, but still way too high. I think Anna makes a really good point about how we get staff engaged, and I think what was positive for me, so there's something about being really specific about what staff can do in their own area. And when I walked about last year, one of the things that we'd started to really push was the estimated date of discharge from patients. So it is a good planning tool, but actually more important, it's also it's really important for families and the patient themselves to understand what we're planning to try and achieve. When are you likely to go home, and what do we need to have in place? And actually we had a really big uptick in the data around that and capturing that, but also the engagement from staff. And when you walk about the ward sisters and others will say, I'm really on it now, and we recognise that and we've pushed our rates up. So being quite specific about individual roles is actually the most important thing here, rather than trying to kind of blanket cover. But also leaving the opportunity for innovation. And I think we did manage to achieve some of that last year, and the frailty work was absolutely from the teams on the ground who wanted to do something different, and then colleagues working with commissioners in the Better Care Fund went, there's a small pot of money here that hadn't been identified where it was going to be deployed. We've got this idea, can we move at speed and try it? And that has turned out to be a fantastic success. We're building on it, mainstreaming it and making it business as usual. So I think there's that balance of, let's really lock down our plans, make sure that everything's as good as it can be, but also let's give ourselves some flexibility to support staff innovations so we can try some things and see if we can actually come up with new ways of working.
That's really great. So first of all, thanks Nicola, really great report, really helpful, and Sue pulling together some of the learning from last winter, dead right, we do it. Overview, actually we did remarkably well. I mean, it was a very tough winter, and some of the performance data and some of the patient experience was not what we want. Of course, none of us like corridor care, but actually, given the circumstances, actually our performance was held up remarkably well. I want to keep on going, Anna, if you don't mind. And that's really striking. We maybe need to remind ourselves a bit of that. This is right at the beginning of the process for June, for next year, so next month we'll have the chance to pick up on some of the points that have been raised here and look for a little bit more expansion, so we'll maybe have the chance to reflect more on the impact of earlier release of patients, discharge of patients I should say. We might hear a little bit more about our processes of moving towards vaccination for staff. I'll be really interested to make sure that the plan next time really does look at flow, looks not just at people coming in the front door, but flow all the way through the system and identifies if there are any other blockages. We noted here, we haven't discussed today, but we'll need to next month, intermediate care and what measures we're taking to mitigate against what seemed to me to be a significant risk emerging within our area for shortage of effective intermediate care places. We've talked about the importance of comms to staff, not just kind of blanket, but more focused. And I think the crucial bit that we were hearing from Rob is the importance of making sure that there's space for innovation for staff to continue to be creative and find their own solutions. I'll be looking forward also in the autumn to be seeing the data coming from Australia, which should enable us to refocus and work out when the pressure points are most likely to come, because we're going to be fleet of foot as we come into this kind of winter. But thank you, Nicola, great work. Should we move on? Patrick, we'll be taking a break after this item. The integrated board report, the normal excellent bringing together amount of material. You know I'm keen to get a little bit crisper with some of the summaries, but it's terrific that we have this data to interrogate. Do you want to pull out what's new, what's different?
Yes, just pull out a few things, Chair, thank you for that. From a quality and safety point of view, I know colleagues would want me to just reiterate around the continued close monitoring of the infection prevention and control metrics. So you'll see from the report there's no statistically significant variation, either positive or negative, in terms of those metrics. We do want to see improvement in those. So this is absolutely being closely monitored by Quality Committee, and I know there will be a deep dive going to Quality Committee on this topic in July. From a performance point of view, still a long way to go in our improvement journey, but in general we are seeing an improving picture with positive variation in 4 of the 7 key performance indicators. And just wanted to highlight one of those areas in terms of cancer performance. So the data provided in the integrated board report was from February, and since the production of the report we have had data for March. And I'm pleased to say that continues to show an improving picture. So we've achieved the faster diagnosis standard, so this is being diagnosed or not with cancer within the 28-day time period. So we've achieved that target again for March as we did in February, and that's the first time we've sustained that improvement since summer last year, so pleasing to see that. We've also improved our performance from a 62-day diagnosis to treatment point of view as well. So while that is still below the national standard, we are making positive improvements. And related to that, the number of patients who are waiting over 62 days has consistently fallen over recent months, and I think we've flagged this before. We're now circa 100 patients waiting over 62 days. That's still too many, but historically it's about half of our historic level that we've seen in previous years. I'll look a more on cancer because there was an update of that in the medical director's report as well. From a people point of view, so mandatory training shows continued improvements, they're being maintained. However, colleagues will see there's further work to do from our appraisal rate perspective. But we do have a new appraisal process and documentation that's been implemented from April. As someone who's used that document on one of my, through the appraisal process with one of my staff, I can say how much better it is and easier to use. Oh, good. So I'm hoping that other colleagues will find that as well as they start to use that.
Around meeting.
And then I was just going to hand over to Joe from a finance point of view. We do have March's position in the integrated board report. It does show we have achieved a balanced plan, but certainly not in the way that we wanted to.
Janice.
Yes, I suppose our plan did include sort of 38 million of sort of non-recurrent measures to sort of achieve that plan last year, but what we actually had to use was 68. In other words, we didn't actually sort of achieve that sort of recurrently. That would affect our sort of, that does affect our underlying position moving into next year, well, this year now. We have submitted a break-even plan. That requires a sort of 106 million CIP. That's obviously significant. Of that 25, we're still assuming is non-recurrent, but that puts a large ask on the clinical boards and the corporate departments, 64 million. We've still got some gaps in sort of identifying that of around 30 million. And I suppose, you know, we're in month one now. I'm thinking about month two at this point, sort of thing. We are still some way to go in terms of, yes, at month one we submitted a position that's in line with the plan, but again, we've had to bring forward some of that, those non-recurrent measures in order to be able to do that.
Well, you focused on that a bit in your initial presentation. Is there anything else you want to say about this? This is going to be an important issue over the line. A lot of our discussions involved, isn't it, this year?
It is, and this is about really getting everybody on board with trying to make sure that we identify and take out any waste in the system and really get all of our colleagues supporting. Joe's right, last year we got over the line and we did everything we could, but it was too much of it was reliant on non-recurrent measures. We need to get that into recurrent measures, and that's really, really important because our medium-term financial plan includes the ability to then make investments, and those investments are about furthering the quality advancement in services that we provide, and we want to be able to have sufficient headroom to do so. The plan this year does include some level of investment, and that is where we've targeted specific areas of concern or risk, and we felt that we needed to put some resource into that, but it's far more limited than you would want to do in an organisation this size. So this year really is a really, really important year for turning the dial and making sure that we get into a recurrent positive financial position, and also all of the flexibility that would come with that with the new national performance framework, particularly around the capital plan which we mentioned earlier, and some of the flexibilities that nationally we're seeing start to be offered if you're in those highest performance segments. So a really critical year. Need lots of support from everybody. It's going to be very important that we remain focused throughout the year on it. The message into the organisation though is it is one that you would expect, which is that all of this has to be balanced with our performance and also levels of quality. So everything we do needs to hold that finance, performance and quality balance, because that's how we then support our people to deliver the best care to patients in a sustainable way. So we will make sure that we've got all of the appropriate checks and balances in place around the development and delivery of any savings plans as well.
Good, well done. Patrick, have you covered anything more you want to add there?
Yes, sir. Thank you.
Thank you, then let me open that for comment. Ian.
Thanks, Chair. I think I just wanted to important to note, which is not covered in the integrated board report, but related. Colleagues will know we've previously reported forward some challenges around outbreaks regarding TB, which is not a particular metric covered within the report. That continues to be an area of focus and concern for us, and there's some learning investigation locally in terms of those outbreaks, in terms of how we manage them and any learning to prevent any future. But it is going to involve review involving our estates colleagues around screening and other measures. So there's a group being put into place to provide oversight for that, and we will of course provide an update through Quality Committee in due course. But I felt it was an important point to mention at this point to bring to the board's attention.
Good, thank you. Julie, do you want to add a word on that?
I mean, just to add, in the future papers, we will try and capture the risk of the state's infrastructure and in the current infections and emerging infections, because that's something that kind of cuts through all things quality, performance, finance. We probably have to have a sort of statement on the current risk that we have in the state's infrastructure.
Yeah, okay. Anna?
Yeah, we haven't touched on it here, but I know we've touched on it at Quality Committee, and I'm sure they've touched on it at the People Committee, our constant inability to hit the appraisal internal target, and I wondered at what specific assurance we could get that we were actually going to hit this target in the next 2 or 3 months.
Vicky, do you want to have a go at that?
Yeah, thanks Anna. I think there was a conversation at People Committee which I wasn't actually able to attend, but Bernie will reflect on that in terms of staff suggesting alternative ways and innovative ways of doing appraisals. So trying to perhaps think about doing it rather than being a very complicated, bureaucratic structured conversation. Could we do something a bit more rapid? Certainly the new appraisal documentation, I think, lends itself to that. But you're absolutely right, it's something we need to have a focus on, but I think the new documentation I'm hoping will help people to see more value in the conversation and therefore more ability to prioritise and making sure that conversation takes place.
David and then Phil?
Just very quickly, out in the private sector, I think they were very expensive. There are some very, very interesting software-based appraisal systems where they're phone-based, you can request that they're organic and they build the pictures, the formality is captured. I think certainly the big four accountants, and Bill might be correct if I'm wrong on this, certainly have those where you have an interchange as you're going during the course of the year, and it's very short specific things then build up, and it takes the complexity out of the appraisal. Now, it's probably quite a big ask when we've got such a lot of other things to do in terms of digital, but if you can sort of replicate that approach as you're going, stop becoming this big, all-encompassing event which distracts everybody, it becomes, I think, a more effective thing. It's also more real time.
Well, thanks for the extra consideration. Yeah, thank you for that.
Yeah, thank you.
I've got Phil and then Dean.
Thanks, Chair. It's a very informative report got in there, and this is a more general question. Picking on the back of the problem with appraisal is also mandatory training, and I was just wondering if we had any update on where we are with regard to reviewing the burden and relevance of mandatory training for all staff.
That is in process at the moment. We're looking at that.
Timeline?
Yeah.
Come back to you, if that's okay.
Okay.
Thank you.
Yes. Vicky's aware that I'm also on Phil's side about wanting to see the outcome of that process. So good. Nini?
I really like the way the report's laid out, and I like you talk about current position, underlying issues and actions undertaken. That's really helpful where we can see if there are targets that haven't been met. I guess I was just wondering about the sickness target, which we touched on already when talking about winter planning and the impact it has on that. I think Ian touches on sickness in nursing staff in your report being consistently above 6% for nursing staff and midwifery staff as well. I know our current rate is 5.75% and that's been increasing, and that we now have a target to reduce it by 0.5%, which I think is good, but the target has been increasing and it's been difficult to reduce it. So just wondering, for us to have assurance about that 0.5% reduction, what are the plans in place? And I guess more importantly, who's coordinating it? Because I know you've touched on the role of the clinical boards. We also have HR, and I know we're transitioning to having HR, BP, business partners. So in amongst all of that, who does what? And is it clear about roles and responsibilities? And who's coordinating it so that we can really try and tackle this reduction?
Bernie, do you want to first bite the fire about what you're saying?
Yeah, I mean, it's a huge challenge, it is you know, because we look at the issue of sickness, absence, and the appraisal and staff at our regular people committee. It's stubbornly high in there is absolutely a huge effort going in across all political boards to try and grapple with this challenge, which I think nationally, across all sectors, and particularly the NHS, has seen a significant uplift sustained post-pandemic. And, you know, getting to the kind of core of that is proving difficult. But we've been challenging, we'll continue to challenge this. We will be deep diving into specific areas where, in trying to correlate the impact of those significantly higher areas of absence with the impact on quality and service delivery, and seeing through deep dives at People Committee what has been done in a supportive and challenging way to try and just change this dial. I know Rob, as Chief Executive, with colleagues, is keen to, you know, we might just need to start looking at this problem through a different lens. Because we've been looking at it quite rigorously through a particular lens for quite some time, and it's proven difficult to turn. I'm personally sure we're certainly giving it the right attention through the executives, but it's proven a challenge, and we need to do more and something different potentially to try and support our staff to be able to work as far as they reasonably can be.
I'm going to take that as a response unless you desperately try.
That's fine.
That's been really interesting and wide-ranging discussion for us. Thank you. So thank you, Patrick. The report has stimulated the kind of debate that we want to have. We focused initially on performance and some really encouraging signs, a few not so encouraging, but overall the balance is more pluses than minuses at the moment, which is good. Can't feel quite so optimistic about finance, but it's still in the middle of the challenges. We've had a separate report on CPE and recognising that this is an issue that hasn't gone away. And then in particular we focused in on 3 People Committee issues. I think we can feel confident that the People Committee is all over appraisals, mandatory training and staff fitness. But it's interesting nonetheless that we actually featured a lot of our discussion this morning on that. But that was a good discussion, and thank you. And this is the moment to take a 5-minute break. It's 11:30. I'm going to try and start us again at 11:35, if we can have a go at that, please. Thank you very much. Thank you very much indeed, colleagues. Thank you for your speediness. Key strategic decision. We need to do something about the shifts to the only 2 loos close to the boardroom, and the locks hardly ever work effectively. So apart from that was a very good break. So thank you. We're into the second half, and almost all these papers have been scrutinised with real care at subcommittee. There's 1 or 2 minor exceptions, but in general, we're into that phase of reporting by exception, and that can be strange, particularly for observers to the public board, because we've got long papers with an awful lot of detail presented before us. The assurance I give to those people observing is that all of this has been scrutinised effectively elsewhere, and this is the kind of the final court of appeal. This is where issues that we really need to make sure everybody has heard brings it up, and it's with that kind of lead-in that I started with the Joint Medical Directors Trust Board report with some really interesting summaries, not all of which you need to discuss.
Yes, thanks, Chair. I give you this paper for consideration, but no. There are a few things in this that I would just like to highlight. So first of all, we've already heard about our current situation in terms of ED performance, which is still not where we would like it to be, but is improving, and I think it's important to note that. And we have plans for further improvement, as we've already heard this morning. Patrick mentioned the fact that cancer remains a major area of focus for us, and again, we are seeing improvements in each of the targets, including the important 28 and 62-day time to treatment targets, and you will see in the paper a significant reduction in the number of patients waiting over 62 days. In other words, that 62-day target, my colleagues, is the time from original referral to the point at which treatment is started, where indicated. and for us is one of the key indicators in the overall cancer performance, and one that we are putting a lot of focus into at the moment. You will also see in the paper reference to changes in several pathways at a regional level, including the provision of breast cancer care, and we are currently providing support into County Durham and Darlington Foundation Trust. One of our colleagues, Henry Kane, is providing a lot of support there because of some service provision difficulties that they have had, and also a reshaping of lung cancer provision across the region, principally in the Durham area, which we believe will improve our overall provision at a system level, and importantly will give us the capacity to deal with the additional activity that will be derived from the targeted lung health check programme. You will also see that we have been putting a lot of work into the issue of harm reviews, particularly for patients who have waited more than 104 days for treatment. Gail Jones, in particular, Gail is the Associate Medical Director for Cancer, has personally put a huge amount of work into this and done a fantastic job in this, and it is a job that we understand from another region that CQC have highlighted us to them as an area of good practice in this sphere, which is clearly very encouraging. In the quality and safety section, you'll see descriptions of our implementation of Martha's Rule. Originally, there was some discussion about whether this programme would actually be called Martha's Rule at a national level, but it is now to be called that. So essentially, this is one of the elements of our response to patients whose condition is deteriorating, and something that we have implemented across adult patients in the hospital, and we are piloting in children as of 1st of July. You will also see reference to the launch of InPhase, the replacement for Datix, which will give us a number of benefits that Rachel and her team in particular will make a lot of use of. And then finally, I just want to update, we've talked in board previously about our changes to job planning for medical and dental senior staff, which we are implementing at the moment. We are partway through that implementation. We have now reviewed the first 600 of just over 1,200 job plans that need to be reviewed. This weekend we will be doing the second tranche of, I think, about 300. And we have got now the information which allows us to fully understand both the costs and benefits of the implementation of the new job planning policy. And Rob and I had detailed discussions with Lucia yesterday with the Joint Local Negotiating Committee on that. I expect that by the end of June we will have a full picture of that across the whole of the hospital. Finally, Rob's already mentioned the switchover to the remote hosting organisation for our EPR, something which opens up some quite exciting opportunities for us from a digital point of view, but it was a major logistical exercise, and I just want to echo Rob's thought, thanks to all of the people who were involved in that.
And I think we should add the boards. This was a triumph of endeavour to manage that upgrade from separate teams across the organisation.
So I'm happy to take any specific questions on this report.
Any questions or comments to Michael on that? And we've got the Safety Guardians report, which is pretty non-controversial, isn't it? It's kind of...
So the only thing to highlight about the Guardian Safe Working report is to make colleagues aware that the regulations around exception reporting, which is the mechanism that resident medical staff use to report situations in which they are working out with their contracted hours, are changing, and they change in the autumn. That will make a significant difference to the number of exception reports that we receive, and will dramatically increase, we predict, the number of exception reports that we increase for a number of different reasons. But it's just to warn colleagues that you will see a significant shift in this reporting over particularly Q3. But we'll discuss that more as it develops. budget implications for us.
Can't wait. Hassan?
Yeah, thank you, Chair. I just had a question around, this is the first time I've seen this report, being new to the board. The report, I can see why we need the report, because it gives assurance to the board that there are safe working hours for junior doctors. But I couldn't reconcile that with the recommendation, because the recommendation talks about continuing, what does it say?
Actually, the recommendation is to note the contents, I think.
Oh, is it? Yeah. It was just continuing to review the workforce. I wasn't sure where the insurance was in terms of, is this actually, are we safe in terms of working hours for junior doctors?
Yeah, no, I think that's an important question to highlight. I mean, the Guardian of Safe Working's primary agenda is to ensure that the working conditions that we have for resident medical staff are indeed safe. Their responsibility in terms of board reporting, interestingly, is largely to highlight exception reporting and the level of exception reporting. We could quite legitimately, however, ask the Guardian to highlight further the assurance that she has in terms of safety.
That would help.
Okay, well, let's try a little bit more. It'd be interesting to get her views next time. She reports quarterly to us, doesn't she? Is it quarterly she comes in? Or is it 6 months now?
Quarterly.
Quarterly. Well,
so I'm just thinking it's a really good report. I know we've had quite a number of debates about the increasing number of resident doctor posts that we have taken on, either funded or unfunded from Heaney. I just wonder whether there's whether either in the report or alongside the report, we could just put some content in about the changes that have been made. Because it's interesting when I read this to think about the increase in numbers of resident doctors that we've actually seen over last year and going into this year as well. And how that aligns to what we're seeing as outcomes from the Guardian's report. Particularly looking at the increasing numbers in medicine of reporting, alongside increasing local costs in medicine. Yeah, I know that's an area where a lot of additional posts have gone in. So I think there's something about us really understanding, are we achieving the outcome from the changes that we're making? Because the risk is we're not. And so I think it'd be good to try and see.
Yeah, and the person who understands this best actually is Gail Haig in medical staffing, who is the absolute guru of all issues around resident medical staffing. So I can have a conversation with Gail about that issue.
But that sounds a constructive action. Yeah, that sounds a constructive action. May not need to come to board, but yeah. Good. So thank you very much for that. Unless there's anything more, we're on to Ian, a really interesting staffing review paper which went to quality and was chewed over properly.
It did.
So anything you need to highlight for us?
Yeah, and there's just two bits on this I want to draw to the board's attention, just one on the AHP paper. Is just to note that the 6 month deep dive report is not because that work is finished, it is a continual process and it provides the board an update at 6 months, and that's really important to note. A lot of this work is complex and continuous. And it's obviously our collective responsibility as a board to have assurance in line with that national guidance around safe and sustainable staffing. The 2 points to note, where there are areas where we are not aligned to best practice in terms of staffing recommendations, that's well known, and where possible mitigating actions are in place. Where the staff review has identified that potentially additional resource is required, that remains under review. We are looking to move resources within existing establishments between departments where that is safe and appropriate to do so, or try different approaches to working. So for an example, particularly in elder people's medicine, we're going to take a different approach on enhanced care observation to both improve quality but also make sure that's more effective.
Yes, I couldn't get the overview of that. I could see that there's a lot of subtle work going on. Overall, the outcome of this process, are we going to increase our staff costs or keep them steady?
In the elder people's medicine, I hope we'll see a reduction by reducing agency staff but using a more focused enhanced care observation team, which improves the quality but also reduces reliance on temporary staff.
Okay.
So there, with those mitigating actions in place, I feel comfortable that the establishment are broadly fit for purpose, acknowledging the additional work that's still required, and some of those areas which are contained in the report.
Anna, was the quality committee okay with this?
Yeah, we were, and I think we just were keen to highlight to board that the budget that has been allocated for staffing this year appears at the moment to fit the bill, so we won't be going to finance with additional requests.
Good, that's really helpful to hear. Anything? Yes.
One is a very daft question, and I just can't remember the answer. Temporary staffing, as opposed to agency staffing. How do you recruit temporary staff? What contracts do you have?
That's the staff bank.
That's the staff bank. Okay, thank you. And there's several references to the reduction in agency spend. Do we have any numbers to it? It's reassuring that Anna said it's within budget, but what sort of savings are we making?
So we can see that actually in the integrated board report in that section around temporary staffing related to unregistered staff, which essentially is the HCA reduction. So it's been over £1 million in the last financial year, just due to a change in equipment control and also the improved vacancy position, reducing reliance on temporary staff as well.
Excellent, thank you very much.
In the light of quality committees, are we happy to receive the quarterly staff and outcomes review and the staffing review report? Yeah, good. That's very good. Then AHP.
Just to bring to the board's attention is a longer report was discussed at a quality committee. Historically, we've never brought an AHP report to the Trust Board, and it really is my aspiration that as we move forward, that we have equal focus and attention across both nursing, midwifery and our allied health professional colleagues. That's really important. But absolutely recognising the existing governance oversight structure is not as strong as it has been in nursing midwifery. So this is the first report to the board which largely looks at a workforce report, but also outlines additional work that's planned for this year to strengthen governance and oversight both through job planning, but also through basic safe staffing governance processes around our HP workforce, acknowledging the challenges and diversity of that workforce. So that report is there for noting. If you take any questions, but as part of my broader aspiration to strengthen HP reporting moving forward.
Did Quality have anything to highlight?
So I think the thing that we highlighted was that we're probably one of the only trusts that are doing something like this. Nationally, there isn't a framework, so I think this is an area of best practice that we should be celebrating. But I think we need a few of these reports just to look at the trends and things moving forward. But we were delighted to receive it.
I'm glad we got the new development post coming in. That's terrific. That will be helpful. Good. Any points, or are we happy to receive? Great. Next up, we're into maternity. Is Jenna online? Yes, Jenna, you're there. This also has gone through the works. So, what do you want to highlight first, Jenna?
There are just three really concise points. The first is obviously the Trust signalled the safety lab around stillbirth rates on the North East North Cumbria clinical indicators dashboard as the paper details further analytics was required. Had a meeting with the LNS yesterday, and it confirms, as we suspected, that the Trust is within the expected confidence intervals, but the complexity of care and the shared care across other organisations has impacted on the rates. So I'll bring an update in future, but that was just for assurance for the board. The areas of risk are around compliance with Safety Action 7 of the Maternity Incentive Scheme. As you'll know from the paper, the ICB currently have not commissioned the Maternity and the Employees Partnership in accordance with the national guidance. And the requirement of the scheme is that I escalate that to board for oversight to ensure the Trust remains compliant within its responsibilities to progress that. And the third aspect, although not detailed within the report, was discussed at Quality Committee as a result of the patient experience elements in the integrated board report, was around the commission and the maternal mental health service, which is a requirement of the 3-year plan for maternity and neonatal care. Unfortunately, the ICB have yet to commission that for Newcastle and Gateshead.
Quality Committee again, Debbie?
So the two latter points were for escalation to board from the Quality Committee relating to Safety Action 7, which would have a financial impact on us in not receiving the funding for that improvement. However, because it's been acknowledged and escalated to board, that wouldn't stop the funding coming through.
Good.
The second was really around the mental health provision, and our women are being disadvantaged locally if they're in our service because the ICB have had the money and haven't devolved it to us, and we've actually escalated that back to the ICB as perhaps Safety Action 7 to seek further assurance from them that the money will be forthcoming and that we expect them to feed back at the Quality Committee next month.
Good, we're on the case. The Governor's loved your presentation on Wednesday, Jenna, as well. That's nice. Yeah, they did, didn't they?
Thanks very much.
Good. Happy to move on to the Maternity Champions report? Yeah, Liz?
Thank you. Well, I think you can see from the report that Jen has just given what a close understanding of both the activity and the data she has in terms of leadership of that area. From the Safety Champion perspective, I can see an increasingly positive cultural shift led by the management team and through the engagement of the management team and the leadership with the staff. There's a very good vibe and tone within the department. We presented to the governors yesterday, and I think a really good story was told to the governors, both in terms of how we assure patient experience and outcomes, but also the work that's going on within the department. For those of you who were listening to the Ward 34 staff and patient story, Ward 34 is within the maternity department, so that person is reassuring and comforting new mums and families. The consequences of the ongoing estates challenges onto the quality of care, the patient and staff experience is something that's been referenced already. Estates have been doing their walk rounds, you're on the case, there is a timeline, and the fact that estates have been visible in the department and there is a timeline for action has again lifted spirits because there is an end in sight. So the concerns around infection control and indeed the visibility of the service within the trust, I think are both within the scope of what's going on and improving the vibe within the department.
I think it's great that as well as the formal reporting processes that Ian and colleagues are responsible for, that we have the left field analysis from the maternity champion, a little bit more informal, a little bit more subjective, giving us a different form of assurance, which I feel comforted by. Anybody want to raise any questions or comments to this? Okay, that's good. I think we're in a good position on this. Well done, colleagues, thank you. Moving on, quality account, enormous report, but actually, again, gone through everything, some real hard work in preparing it, and a lot of consultation that we're being asked to approve it today for publication, aren't we?
Yeah, and it'll go back to Quality Committee for final sign-off. We are still in our 30-day consultation period until next week, so happy to take any comments from people or recommendations. We've had some feedback from our stakeholders, various overview and scrutiny committees and our ICB colleagues, so we are working towards implementing those recommendations moving forward, but overwhelmingly positive feedback about how honest we've been and glad to see some improvement.
Yeah, well, that's, I think, great piece of work. Anna?
So we just would like board to delegate the final sign-off to quality, please, so that we can do that at the next quality committee, because we won't have a public board after that.
Are you happy for us to do that, colleagues? They will delegate the final decision on quality account.
Yeah.
Good. Excellent, then. Thank you very much indeed for that, Rachel, and thanks to all those colleagues that have been involved in it. Committee chair meeting logs. This is entirely by exception, but just running through any issues that chairs need to raise. Bill, for the finance and performance?
Nothing to raise, exception. No.
Thank you. Quality, Anna?
There was only one other final thing that would escalate from last week's meeting, which was around the provision of integrated care beds, and Rob has agreed to take that through today's meeting.
Intermediate care beds?
Yeah, we are concerned about the impact of the loss of those 45 beds and thinking about next winter.
Am I right that we've actually managed to secure a stay of execution on the...
So the building work that was required by the local authority on their facility is going to be done differently. There will be a smaller number of beds for a shorter period of time that will be unavailable, but the major works will be next year.
Okay.
We've got commitment to work through developing an intermediate care strategy prior to that.
Good. Okay.
And we've obviously got the mitigations that we've put in place around the beds that NCD commissioned, which we've opened at the Freeman Hospital. Clearly we want a much better out-of-hospital strategy for those in the long term. So
it's
right
a big
now
issue,
the
yeah.
safety is being managed, but
Yeah.
it's not the right setup.
Okay, that's good. Thank you for explaining that. People committee meeting?
Yeah, nothing further than the items we've discussed today, Chair.
Thank you. Charity committee, Phil? Thank you. Audit and risk, David?
Just one very quick point, because it's been raised here before. We are going to be moving to a bi-monthly ARAC very shortly. And one of the objectives of that is to release time back to clinical and executive colleagues to focus on other things rather than sitting with large numbers of us in a room and ARAC to give it a leaner focus. But we will probably have slightly longer meetings, giving us a bit more depth when we need it.
Very good. and digital and data. We haven't got the minutes, the log.
Yeah, I'm not entirely sure.
It was only the beginning of the week, wasn't it? So yeah.
Oh right,
Anyway.
maybe that was it. The only point to mention is that there's a change of chair, so I'm handing over to Hassan from the next meeting, and that we've had a sort of transitional meeting with Dave Elliott, so looking smooth going forward.
Good, thank you. It wasn't the beginning of the week, but yeah, okay, thank you. Okay, then all good on that. Let's move on to really interesting papers that were properly tuned over also at People Committee, weren't they? And the race equality and the disability equality data. We need a board decision to approve the publication. I think we kind of show ourselves that the discussion actually was brilliant because I thought the reports were terrific. Vicky, do you want to introduce these two?
Sure, thank you, Chair. Yes, so every year we obviously have a requirement to report on our disability and race equality data, and so the request is that data is published. Just to be clear though, these reports are not action plans about correction, so I want to be clear about that. And there are a couple of other points which I think it's important to raise in this forum. So from the disability data report, there are 10 indicators in their report, and whilst there are moderate and modest improvements on 9 out of 10 of those, if you look back to when that data was first started to be collected, actually the improvement is not particularly significant. Yeah. So I do want to make colleagues aware of that, because what we tend to do is year-on-year comparison, and you don't actually see the overall trend. Likewise, with the workforce race equality data, there are 9 metrics there, modest increases in 6 out of 9, but there are 2 particular indicators in there, I think, where we have some genuine concern. One relates to indicator 3, which indicates that BME staff are 1.5 times more likely to enter into formal disciplinaries. That's a new figure for us, that is of concern to us. And the second is indicator 2, which is also very concerning, which says that BME staff are nearly 2 times less likely to be appointed into new roles. So I wanted to make sure that the board was fully cited on that, because I think it's easy to convince ourselves we're doing better than we are. That's all I wanted to say. And Bernie, did you have anything you wanted to add?
Yeah, just to confirm the summary, Chair, it was, I think, thoroughly and somewhat robustly, I think, discussed and debated at the People Committee last week. Lost losing track. And I think, I think a lot in the candid assessment, looking back over a longer period of time, but quite frankly, it's not acceptable. And that was the tone of the constructive discussion that we had at People Committee. But from these annual reports and data sets, there will be targeted action with a clear expectation, more demonstrable improvements made.
And we know there's a lot of work going on developing the equality diversity that Caroline, you're part of leading.
Yes, I just wanted to make the link back to that and to the development session that we had as a board quite recently. We know that we've been doing a lot of that conversation with different key stakeholders around both race, disability and the other equality streams. And I think we've all acknowledged how much work we've got to do in this area. We have a group of people actively working to develop an anti-racism policy for the organisation. And I think what we're really looking at, with the support of lots of people around this table and outside of this room, is a real step change into how we address some of the challenges we have around equality. So it's fantastic that we've got so much information about this, because it really does help us to focus down on how we can make the biggest difference. So.
Good, okay. So I'm sorry.
Yeah, I just wanted to echo what Bernie said about the report. We had a really helpful discussion at the People Committee, and I think we talked about how the figures from the Working Race Force Equality Standard, but also the staff survey over the past 11 years really haven't changed that much. And just to bring out some of those key points, we talked about nearly 1 in 5 people from a BME background experience discrimination from their manager, nearly 1 in 4 experience bullying from staff, and nearly 1 in 2 that there aren't equal opportunities for career progression. And I think we were all, equally, convinced that we need to change those figures. And there's been some fantastic work that's been done at the EDI workshop. We had a board development session on this. Really helpful ideas about thinking about key principles, priorities and an action plan, which hopefully will start to turn the dial on some of these figures. So I just wondered what the timescales are for that.
So we're working through, you have to forgive me because I've been off on holiday for the last 2 weeks, so, but we're working through what that might look like. We've got a session in next week. In fact, we're using the EDI steering group next week as the place where we will have that discussion about what all of those bits of intelligence tell us and how we can actually get into a really firm action plan around that. We would want to do that aligned with the People Plan Year 2 objectives and the timescale for that being published. I think it still is July.
Yeah.
So certainly this is very much something that we're working on all the time to get. So don't feel that we're not doing anything in the absence of that plan. We're very much trying to move forward in a positive direction.
Hassan.
Oh, thank you, Chair. I don't want to repeat what's been said already. I thought I'd share my reflection on reading this paper. So I think the figures are stark and they're alarming. And just as a board member, just to tell you how I feel when I read this, it's actually really deeply hurtful when you read this. And so my concern is, as we head into what is quite a challenging financial period, I think Robbie mentioned that we've got almost like freeze on corporate spend. My concern is that other priorities or lack of capacity or capability will hinder what we need to do here. So all I'm saying is I want us to really stay on this and urge us to really focus on, and I know you will, and I've got that trust because we've talked quite a lot about what we want to do. But this is quite hurtful when you read it, and it will be the same for your colleagues out there, and this has a direct link to patient outcomes, because the more included we feel, the better we perform, the better outcomes for patients. So just wanted to share that with the colleagues. I know you know that already.
And I think we can safely say that is a genuinely widely held view among board members. So we're asked to approve the publication. That's a very kind of bland decision we need to take, and of course we're going to do that. I think we probably, in the light of this, just reaffirm our commitment to be developing a robust action plan that will be owned by staff and owned by our board, that will see a way of turning the corner on these data. We know that things take time. I think none of us are naive on this. But if we can't produce a plan that shows the curve turning, we should be ashamed of ourselves. So I look forward to work progressing at pace in this area. Thank you very much indeed. Colleagues, then we're into this next section is quite exciting, Kelly. We're being asked to approve the annual reports of the various committees. And do you want to introduce them?
Yeah, just to highlight that the committee reports have been around all of the individual committees and been reviewed and given feedback received. So we'll put them forward for approval today. Happy to take any comments or questions.
Are we happy just to receive? Yeah. The charity committee similarly?
Yeah, do you want to?
The same, anything you want to add to it?
No, we were just a little bit delayed. They're not in the full pack because our meeting was only last Thursday. So
actually, we've got it is in now.
Yeah.
It's just coming.
It's the terms of reference we haven't got. We had an interesting meeting which let us all reflect at the end of the meeting, so we have to go back to look at the terms of reference again.
Okay. But all committees are operating effectively at the moment. I mean, it really feels like they're, I won't quite say smooth running machine, but yeah, I've just said it, haven't I? Well, I'll carry on with the team. On we go. We're into the meeting log. Sort of a good count. There's one red which is, if I say it's trivial, it's an information exchange. I think you need to get to the point with action logs where just because it's an action, sometimes it takes a bit longer, it's a bit more complicated. We don't need to take up all the time with it. So Ian, you want to respond to that?
Just on that action, I'm not sure it needs to say it's an action on a board action log. I'm happy to take that, which is a request to see whether or not there's any benefit in sharing progression of maternity incentive scheme across providers. That's not been easy to get into, but actually I don't think it changes the work that we're doing internally. So perhaps because it's a possibility, but I don't think there's any reason.
I'd like to close it down as an action. Carry on with it, but it's just not a broad one. Even if it was a good idea and not appropriate. Yeah. And there's nothing else I need to highlight, I think, from the action log. We're all good. And that's a satisfying set of greens. There were no any other businesses, so I'm able to bring the meeting to a close. Thank you.